is Jessica Hubbard, and I am a manager for the Community Education Department at MDA. We're thrilled to have you join us for today's Research and Care webinar on vaccines and neuromuscular conditions, safety, science, and guidance. This learning event is part of our larger MDA Community Education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section of nda.org for updates on upcoming events. We are recording today's event and we'll be posting it to, the website for on-demand viewing at a later date. Everyone registered for today's session will receive that information in their inbox. Please know that all lines have been muted, but you can always ask questions. We'll have the chat open for questions, and we will hold the Q&A session at the end of the speaker's presentation. Simply use the chat feature to type in your questions, and feel free to type your questions and send them in as you think of them. No need to hold on to them until the end, and we will address them after the presentation. We also have the questions that were provided during registration, which we have shared with Dr. Hernandez to be able to answer those as well. All right, I want to be sure to thank our sponsors, our program supporters, Alexion and Biogen. And for nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, access to care, advocacy, education, recreation, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. Our community education and recreation programs are designed to connect individuals and families. We're committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. And every year we offer over 40 educational programs, over 20 summer camps, and dozens of other community activities, both in person and virtually. If you haven't done so already, we invite you to join the MDA community by registering with us. Registration is free, and please see the link in the chat to do so. And then, of course, to learn more about MDA, please visit mda.org. It is now my pleasure to introduce our speaker, Dr. Amanda Hernandez. Dr. Hernandez is an assistant professor and chief of neuromuscular medicine at the University of Connecticut School of Medicine. She practices in Farmington, Connecticut, and prior to joining the faculty at University of Connecticut, she was at Yale University, where she completed her MD, PhD in neuroimmunology, residency in neurology, and fellowship in neuromuscular medicine. Her research has been highly esteemed, having graduated with distinction amongst other recognitions. Outside of her clinical practice, she is active in leading innovative clinical trials, educating medical students and residents, building a curriculum focused on health systems, and facilitating translational research with a focus on neuroinflammatory conditions. Her current research interests include autoantibody characterization in diseases like myasthenia gravis and CIDP. In her free time, she enjoys being outdoors, exercising, and spending time with family, friends, and her two Bernedoodles. So Dr. Hernandez, thank you for being here today. I will hand things over to you.
Thank you so much for having me. So we are here to talk about vaccine safety and neuromuscular disease, and we are going to briefly outline an agenda in just a moment. Before I get started, I just wanted to send a sincere thank you to everyone at the MDA who has invited me to share some of my knowledge and expertise with you today. It is a passion of mine to educate patients and to advocate for my patients. And so I really appreciate, again, the ability to be able to spend some time with you all today. I do want to say that I am more than happy to answer questions that are related to what we're going to be speaking about today. But it is going to be hard for me to answer questions that are related to a specific part of someone's disease. For example, I cannot provide medical guidance for patients that I have not actually seen. So I'm more than happy to answer questions that are pertinent to what we discussed today, but it's going to be hard for me to answer individual diagnostic questions. I encourage you to reach out to your providers to address those accordingly. And with that, we are going to dive into our agenda. We're going to first talk a little bit about how vaccines work. I think it's important that you all understand the different types of vaccines that are available and out there, especially because some vaccines are considered to be safer for certain conditions over others. We're also going to take into account, given that, considerations that are related for those neuromuscular diseases in patients who are considered to be immunocompromised or immunomodulated. We will discuss why certain vaccines are recommended prior to receiving specific treatments for neuromuscular disease. I will share some reliable sources for you all to refer back to when making decisions about vaccines, either for yourself or for your loved ones. And then, as Jessica said, we will have about 15 or so minutes at the end for questions. And again, that chat box is open. So if you have any questions that come across as we're going through the slides, please feel free to drop them in real time, and we will address them at the end of the talk. So without any further ado, we are going to review a little bit about how vaccines work. There are many different types of vaccines, and I have listed the main ones here, namely those that are live attenuated, inactivated, considered to be a subunit or a part of the virus, pathogen, or bacteria that is going to have a response built for it. There are vaccines that contain the actual toxoid or toxin itself. Some that contain genetic instructions for the body to make a specific type of immunization to a certain bacteria or virus, and then those that use modified virus itself to deliver genetic material to cause the response for the immune system to occur. We are going to spend a little bit of time going over each of these categories, and we're first going to start by talking about live attenuated vaccines. So these are vaccines that contain a weakened form of the virus or bacteria. So they do contain something that is considered to be live. And they work quite simply by mimicking what naturally would happen in our body if we were exposed to that specific virus or bacteria. And by doing so, they're able to trigger a very strong and long-lasting immune response, kind of bringing in all of the cavalry and all of the key players and allowing our body to, again, mimic what would normally happen if we had that infection and prepare that body to fight any future infections that are related to a related virus or bacteria. The pros associated with live attenuated vaccines is that they really only often need about 1 to 2 doses for lifelong immunity. The cons is that they're quite simply not safe for patients that are immunocompromised because of the fact that they contain a weakened form of the virus or bacteria. So if a patient has an immunocompromised state of their immune system, we usually wouldn't recommend these. Another con that may not be as relevant for you all is that they often require refrigeration because they contain a live weakened form of the virus or bacteria. Some examples of vaccines that fall into this category include measles, mumps, rubella, the chickenpox or varicella, and yellow fever. Many of these are vaccines that we would have had when we were much younger, and not necessarily vaccines that we would happen to have to be re-exposed to in adulthood, although there are certain considerations for that do vary on a case-to-case basis. The second type of vaccine that we'll discuss are those that are inactivated or killed. So they use either viruses, bacteria, pathogens that have been killed or inactivated. So these are not live, nor are they live or weakened forms of the virus or the bacteria. And they work in the sense that they are safe even for immunocompromised patients because they do not consider they're not considered to contain anything that is live, and they also cannot replicate, right? So that strong immune response that we talked about in the previous type of vaccine is not going to happen here because these vaccines do not contain a live form of the bacteria or virus, weakened or otherwise. There's no risk for causing disease because of this, which is considered to be a pro. And the con being that it results in a weaker immune response. So oftentimes you need to have multiple doses, you need to have boosters, you need to remind the immune system what it is that it's fighting against because you are providing the immune system with something that is already killed. So the most salient example of inactivated or killed vaccine is the flu shot, which if you're any bit like me, I work in healthcare, so I get my flu shot every year. I need to get that booster because it does not contain something that is live. It is a killed form of that flu virus. Other examples include polio, rabies, and hepatitis A. The third form of vaccine that we will discuss include those vaccines that contain only parts of the pathogen, the virus or bacteria. So whereas with the killed and inactivated form, we took something that was previously live, we made it no longer alive, it's killed, and then we're allowing the immune system to respond to that. And these forms of vaccines, we're only taking a certain part of that virus or a certain part of that bacteria to then prime the immune system to create a response. And this is why they're called subunit, recombinant, polysaccharide, conjugate vaccines. All of these are kind of fancy names that we use to describe the parts of that bacteria or the parts of that virus that we are then using to prime the immune system to create a response to. Because we're only using a small part of that virus or of that bacteria, we're focusing the immune system to respond to specific parts of that to build their response. They are considered to be very safe because of this. There's no live components. There's nothing in it that is a complete virus or a complete bacterium. And it really, again, just primes the system based on that small part of the bacteria or the virus that is contained to have an appropriate response accordingly. Some of the cons is that they may require additional supportive vaccines or additional boosters to maintain strength of immunity, because again, we're only dealing with parts of a bacteria or parts of a virus to build that response for the immune system. And some examples of this include hepatitis B, HPV, and the pneumococcal and meningococcal vaccines, all of which are quite commonly given in adults and through adulthood. And we are going to spend some time talking about meningococcal vaccines a little bit later in this talk because they are a very important point to address, especially in those that are navigating neuromuscular conditions. The following type of vaccine is considered to be a toxoid. And so certain bacteria produce certain toxins, and these vaccines take those toxins, they inactivate them, and they effectively teach the immune system how to neutralize that toxin. Our immune system functions like a great big arsenal. All of these different players come into the field to help fight whatever sort of infection is happening. And oftentimes with bacteria, they create toxins that parts of the immune system are able to neutralize so that you don't end up having as bad of an infection as you would have had otherwise. And when you're exposed to a toxoid vaccine, you're effectively teaching the immune system how to neutralize that toxin before it's been exposed to that toxin, rather than necessarily expecting the immune system to respond to the bacteria alone. Some examples of this include diphtheria and tetanus. We don't necessarily see a lot of toxoid vaccines as like things that we have to be boosted against or taken from a year to year, but it's still important for us to recognize what these are. mRNA vaccines use messenger RNA to tell our body how to make a harmless piece of the bacteria or the virus's protein structure. So effectively, it's teaching our cells, teaching our body to produce this so that then the immune system can trigger a response. So this is effectively taking what we learned about those polysaccharide, conjugate, and subunit vaccines and kind of taking it to the next level. So rather than providing our body with small pieces of that virus or bacteria, we're teaching the body how to make that and then allowing for the immune system to create a response against that portion of polysaccharide, subunit, conjugate, what have you, that's part of the bacteria or the virus. These vaccines are fast to produce a response. There is no risk of infection associated with them because they are not considered to have anything live or active within them. And some examples include the COVID-19 vaccine from Pfizer or from Moderna, which I'm sure we're all very much well versed in. And that is probably the most famous or popular mRNA vaccine that's currently on the market right now. Viral vector vaccines use a harmless virus, something that does not create an immune response or cause any sort of illness. to deliver a material that comes from the virus or the bacteria, and then allows the body to have an immune response to that. So this is kind of similar to the mRNA vaccines in a certain way, effectively allowing the body to create a response to a part of the virus, a part of the bacteria, so that they can have your immune system can have an appropriate immune response. Examples of this include the Johnson & Johnson COVID-19 vaccine, which is distinct from the Pfizer and Moderna vaccines. And another example is also the Ebola vaccine. Thinking specifically about some important considerations for patients and loved ones that are living with neuromuscular disease, neuromuscular diseases are considered to be very varied and very unique. The type of disease that you have is really going to help us to understand what types of vaccines may be encouraged. There are neuromuscular diseases that are considered to be genetic. There are neuromuscular diseases that are considered to be inherited. And there are neuromuscular diseases that are considered to be autoimmune or inflammatory in nature. And recognizing what type of disease you have, again, really allows you and your provider and your care team to be appropriately educated as to what vaccines may be required. It's also important to note that the type of medications that are used to treat some of these neuromuscular conditions may also require vaccination prior to initiation of treatment. And the most popular example of that is complement inhibitor therapies like Soliris or Ultomiris, for example, which is eculizumab or ravulizumab in the treatment of myasthenia gravis. There's the requirement that you have to be vaccinated prior to beginning those. And we are going to talk much more about that, as I alluded to earlier. Some examples of this to dive in a little bit deeper include patients who are considered to be immunocompromised or immune modulated. And those are patients that are on some of the following therapies. And again, a lot of how therapies are chosen, a lot of how vaccine recommendation is provided is very much based on the type of neuromuscular disease that you have. So patients who are considered to be immunocompromised or immunomodulated include patients that have been exposed to or are continuing to take prednisone in higher doses. Patients who are on mycophenolate, which is the generic name, brand name is Cellcept, azathioprine or Imurin, methotrexate, rituximab or Rituxan, and some of the newer therapies that target the FC receptors like efgartigimod, Imavi, and rozanolixizumab. And those are known as nipocalimab or Imavi, and Ristigo. Complement inhibitor therapies include Soliris, Ultomiris, and Zilbrysq, also known as eculizumab, ravulizumab, and zilucoplan. And again, we are going to dive a little bit further into those complement inhibitor therapies because they do require vaccines prior to initiating therapy. Rituximab, just to go specifically into some of these, is used in a variety of neuroinflammatory and immunologic conditions. It is considered to be a B-cell depletion therapy, meaning that it takes a small part of the immune system, the part that is responsible for creating antibodies, and it puts it to sleep temporarily. It's important for me to note to you that the part of the immune system that it tucks to sleep temporarily is not the entirety of the immune system that creates the antibodies. It's only a portion of it. So given this, it's encouraged to be fully vaccinated with age-appropriate vaccines prior to starting this therapy, because again, we're taking part of your immune system that's responsible for creating those antibodies and we're putting it to sleep. I often get asked by my patients, well, what happens if I'm on rituximab and I want to get my COVID vaccine or I want to get my flu vaccine? And I tell them, usually rituximab is dosed every 6 months. Let's get you your vaccine about a month prior to getting your dose of rituximab. Factoring in that at that point, that part of the immune system that we're putting to sleep is probably starting to wake up, therefore increasing your probability of having a good response to the vaccine that you're being provided. It's also important for me to mention to you all that rituximab takes that part of the immune system and it puts it to sleep in the periphery of your body, but it doesn't necessarily put those same parts of the immune system to sleep that live within your organs and within your tissues. So you will still, regardless of where you are in your rituximab cycle, you will still have some response to whatever vaccine that you are provided. But nevertheless, it is crucial to get age-appropriate vaccines prior to initiation of rituximab. And if you do require a booster, you certainly can do that while on this therapy. And the timing is something you absolutely should discuss with your neuromuscular specialist or your neurologist. FcR inhibitor therapy, which is commonly used in the treatment of myasthenia gravis or chronic inflammatory demyelinating polyneuropathy, or CIDP, it effectively targets the body's recycling mechanism for antibodies. The body is a smart place. And rather than having these antibodies constantly have to be made by the immune system, it actually takes the ones that have already been made of a certain subset, and it prevents them from being degraded. It allows them to live longer. It recycles some of these antibodies. And as I've alluded to, these therapies do not target all antibodies, just the more mature ones. So those people that are on FcR inhibitor therapies are mildly more susceptible to infections, but not necessarily that much more than someone who wasn't on these therapies would be. And given this mild increase in susceptibility to infections, it's important to maintain full vaccination with age-appropriate vaccines whilst being on these therapies. It is important to note that for these therapies, you want to avoid live vaccines. We just went through all of the different vaccine types. And again, live vaccines should not be given with FcR inhibitor therapy. And just to kind of drive this concept home a little bit further, I have a picture here to show you. That Y-shaped figure is what a very, very, very zoomed in picture what an antibody normally looks like. And you can see in that picture that that antibody will bind to the FC portion and then ultimately get pushed through a system that then recycles it back out into your circulation. Again, the body is a very smart place, and it does this specifically for the more mature antibodies. Transitioning a little bit to complement inhibitor therapy, which I've mentioned several times over, we are going to dive a little bit more into, and now we're at that point. I want to talk a bit about recommended vaccines prior to starting this therapy. And to do so, I want to provide you all with a brief synopsis of myasthenia gravis, just to help you all understand why this is something that we encourage. In this image here, you see a blue representation of what the nerve looks like. That pink kind of swirly structure at the bottom is the muscle itself. And you can see those little circles in the purple structure that have tiny little vesicles in them. And those vesicles contain acetylcholine. And when the acetylcholine gets released into that white space between the purple structure, which is the nerve, and the pink structure, which is the muscle, it ultimately binds to a series of receptors that then ultimately trigger the muscle to contract. So the nerve tells the muscle what to do, and the muscle then does it. In order for the muscle to do it, there has to be enough of a response between those vesicles that contain acetylcholine, again, being released into that white space, allowing them to bind primarily to the acetylcholine receptor so that the acetylcholine receptor can respond and, again, allow the muscle to move. What's important to note in myasthenia gravis is that a number of pathogenic or bad antibodies, if you will, come into play and more often than not target the receptor, the space where that acetylcholine will bind, also known as the AChR or acetylcholine receptor, which you can kind of see on the rightmost part a little bit bigger on the image. It looks like a teal-shaped sphere, if you will. And when those antibodies target that acetylcholine receptor structure, it prevents that signal from going from the nerve to the muscle. So you can imagine if you're someone that's suffering from myasthenia gravis, you aren't really able to have full contraction of that muscle for longer periods of time. Thinking a little bit more about complement inhibitor therapy and how this plays a role in preventing myasthenia gravis symptoms and preventing worsening of myasthenia gravis disease, it's important for us to recognize that those antibodies that are specific for acetylcholine receptors have parts of them that pull in other portions of the immune system. And when those portions of the immune system are pulled in, it's kind of like calling in the cavalry. And part of that cavalry involves the activation of something that's called the membrane attack complex. And that membrane attack complex gets pulled in when cavalry, called complement, activates it. And the activation of this complex ultimately causes destruction of the architecture of the surface of the muscle in myasthenia. And when that happens, it can cause irreparable damage. And when I explain this to my patients, I kind of describe it almost like you've got these abnormal proteins, you've got these abnormal antibodies. They get to the point where they're able to prevent that acetylcholine from signaling the muscle itself by creating a problem at the acetylcholine receptor. And when that happens, it calls in this process that kind of creates like a Pac-Man, and it can chomp, chomp, chomp its way through the muscle. And when it does that, it can create irreparable damage. And what complement inhibitor therapies do is they ultimately prevent that membrane attack complex from being activated. The therapies on the market are complement inhibitors at the C5 level, which is at the very end of that cascade of cavalry that I alluded to earlier. And again, by blocking that final step in that cascade, they prevent the membrane attack complex, or Pac-Man, if you will, from being generated, thereby preventing destruction at and deterioration at the muscle, at the neuromuscular junction itself. Because many parts of the immune system use the complement cascade and use the membrane attack complex to help prevent any infections from becoming too severe, it's important that we vaccinate against one in specific, the meningococcal infections, so that we prevent any sort of secondary issues from happening when we stop the membrane attack complex from being able to function appropriately. The way that we vaccinate against meningococcal infections involves kind of one of two ways, and I'm going to go through each of these in detail. And of course, at the end, again, I'm more than happy to address any questions that you may have. There are two main vaccine subsets that are utilized to vaccinate against meningococcal infections, and that is the MenACWY or MenACWY, which is from a brand name perspective known as Menveo or Menquadvi, and the MenB or Bexsero in one case, or Trumenba in the other case. And the most important thing that I want to make you all aware of is that you cannot interchange the MenB vaccines. So once you commit to a specific vaccine series with either Bexsero or Trumenba, you cannot switch. So we're going to walk through this carefully together. You will get both the MenACWY and the MenB, either Menveo or Menquadvi and Bexsero in the first instance demonstrated here. You get your first dose in day 1, second dose at month 2. For the MenACWY, the 2 doses have to be at least 8 weeks apart. And then in the case of Bexsero or MenB, you get your third dose at 6 months after your dose at day 1. So in the case of MenACWY, you have 2 doses, at least 8 weeks apart. And in MenB for Bexsero, you have 3 doses at 0, 1 to 2, and at 6 months. For MenB, a single booster at 1 year after completion of the primary series is something that should be done, and then every 2 to 3 years if the risk remains. So for example, if you're someone that's taking a complement inhibitor therapy, you would be someone that would want to get those boosters. You would fall into that category of having a risk that would require that. In the second instance, the Bexsero is replaced by Trumenba, and the rules are still the same. The only thing, again, that I want to drive home is that you can't interchange between the MenB vaccines. So when you commit to Bexsero, you're committed. When you commit to Trumenba, you're committed to that. The Menveo and the Menquadvi, if you had to, you could, but it's always better to kind of stick with the primary vaccine that you started with. So in the second example, you get your 2 doses of your MenACWY at least 8 weeks apart. And then you get your 3 doses of Trumenba at 0, 1 to 2 months, and again, 6 months after the first dose. And just like in the case of Bexsero, for Trumenba, you would get another booster a year following completion of your primary series. And then every 2 to 3 years if you still have a risk at that time. And as I said earlier, if you are someone that is on a complement inhibitor therapy, you certainly would fall into that risk category. So you would want to follow the booster schedule, and you would want to follow that schedule carefully. With respect to what reputable sources are available to you all, to dig a little bit deeper into this, to make sure you understand exactly what type of neuromuscular condition you have, what sorts of vaccines would be recommended for you. The following resources are places that I would recommend getting started. The CDC and the World Health Organization, National Institutes of Health, the MDA, for which we're here together on behalf of today, the Myasthenia Gravis Foundation of America, or the NGFA, and of course your neuromuscular specialist or your neurologist. Several of the images that I showed to you were kind of taken from sources from different pharmaceutical companies that are educating patients about their drugs, and you certainly can go to those websites as well. But I prefer a non-biased approach to getting information of that domain, and so I really do recommend the sources that are listed here. And with all of that information that I've just kind of filled your brains with, I'm going to take a small pause and see what questions I can answer for you all.
Thank you so much, Dr. Hernandez. I'm looking in the chat, so if anyone has questions they would like to place in the chat, please do so. I do have a lot of questions that were shared from registration, so I'm going to go ahead and start with those, and then as people post in the chat, we can get those questions answered as well. So the first question that I have is, what vaccines or boosters do you recommend for COVID-19 and RSV for someone living with neuromuscular disease?
I would probably go for the Pfizer or the Moderna vaccines for COVID-19. As for RSV, I'm not as familiar with different subtypes. I think there's one major RSV one, if I'm not mistaken. And I don't really have any main suggestion for that. But I would say for the COVID, I've had the most success with my patients that have had either the Pfizer or Moderna, which again are mRNA vaccines.
Wonderful. Thank you so much. And just kind of following up on that, we had several of the same questions just worded a little differently. And you kind of touched on this in your presentation already, but is the COVID vaccine safe to get for someone living with neuromuscular disease in general?
In general, I encourage my patients to be vaccinated against COVID, vaccinated against flu. There are several neuromuscular conditions that can affect diaphragm strength and the ability for our lungs to kind of take in more full breaths. And we do have to be able to do that to clear our lung passageways, if you will. And so I do encourage my patients that feel comfortable, that feel safe, that have discussed it with their primary care provider and all of that, to have vaccines of COVID, pneumococcal, RSV, all of those. Yes, absolutely, I do consider those to be safe. There are certain instances where I might shy away from that, but for the most part, as long as it's a conversation between myself, the patient, and their primary care provider, that usually has been okay in the past.
Wonderful. Thank you so much. And then another question came about the shingles vaccine. I haven't really heard much about that vaccine in the talk, but is that a recommended safe vaccine for people living with neuromuscular disease as well?
So there are versions of the shingle vaccine that are live, and there are versions of the shingles vaccine that are considered to be inactive. I would say it's always best case, especially if you're someone with myasthenia or CIDP that's on any of these therapies, that you're going to want to stay away from live vaccines. So what I will tell my patients is have a chat with your PCP, make sure that they're aware that you are on these therapies, that you have this neuromuscular condition, and let's just make sure that we get you the vaccine that is not considered to be live. And I haven't had any issues with my patients with that, knock on wood, thus far.
Wonderful. Good to know. Let's see. Will the updated COVID vaccine be available for most patients, and is it recommended? So you're saying that you recommend the COVID vaccine, and that includes any updated vaccines that are out there, I assume?
Correct.
Wonderful. Thank you so much. Let's see. And you've gone over this quite a bit, and you've pretty much just explained it about the live versus dead vaccines. So you're suggesting that the live vaccines could sometimes not be what they want to go for, that the dead vaccines, and up that in quotes,
Right.
might be the better of the two options.
Sure. So for the most part, I'm just scrolling back to that
Yeah, no,
screen.
thank you.
So for the most part, the live vaccines are, in my opinion, the vaccines that we probably would have gotten when we were younger, if we're living in the US, for example. Um, and I haven't really encountered a need in a lot of my patients to have the need for live vaccination. Again, keep in mind that the shingles vaccine is available as an inactive vaccine. In the US, that's considered to be the Shingrix vaccine. And for that purpose, there really hasn't been a need for me to kind of address this specifically because most of my patients have already been vaccinated against these things many moons ago. If there is a need for a booster of any of these, and we usually approach that on a case by case basis, again, recognizing that there are some considerations in people who may have had older versions of like some of the vaccines for measles, for example. But yes, I usually avoid that with my patients for the reason, and the inactive vaccines usually are preferred. But for the most part, a lot of the vaccines that you would be getting, apart from the flu, at least nowadays, if we're talking about COVID specifically, those are mRNA or viral vector vaccines.
Wonderful. I think it's kind of understanding which fall into each category. Maybe it
Right.
helps to clarify that as well. Thank you so much. Is the HPV vaccine recommended for people living with neuromuscular disease?
That is a conversation to have with your PCP, and if you're a woman, I would say with your OBGYN. That is what I would consider to be if there was a patient in front of me asking me that question, I would say that is a personal choice. Um,
And that makes
I would
sense.
I would yeah, I would say have that conversation, see how you feel, understand the risks versus benefits, and make the choice that feels the right choice for you to make.
Wonderful. Thank you so much. And it seems like we're having some, I'm not sure where the questions are going, but I see maybe Candace and Julia and Stephanie, if you guys have questions that you wanted to post, if you want to just put them in the chat, you can click down at the bottom where it says chat. You can click those two kind of speech bubbles, and then you can type it into the chat. And I'll be able to see your questions there and share them with Dr. Hernandez. Okay, but moving on. And we still have plenty of other questions from registration to get to while we're waiting on those to come in the chat. Let's see. If someone gets sick, excuse me, after a vaccine dose, is it typically recommended to continue to get the next dose or to get that vaccine again?
It depends on what we consider to be sick.
Okay.
And that
Okay.
is going to be on a case by case, patient to patient example. A lot of people will have soreness of their arm or a little bit of a fever that can
Sure.
happen after vaccination. That's not something that would shy me away from encouraging my patient to complete a meningococcal series, for example, if we are starting a complement inhibitor therapy. But I do recognize there are some distinct or maybe even more severe cases that may come up, and that would be a case by case conversation to have with your neurologist or neuromuscular specialist.
Wonderful. Um, Okay. The question in the chat that just came through is for individuals with neuromuscular disease who are starting therapies like eculizumab or Ritux. Oh, it just moved on me. I'm sorry. Or rituximab. What's considered the optimal timing window for completing recommended vaccinations before to ensure adequate immune protection?
So eculizumab and rituximab are very different medications. As I stated earlier, rituximab is considered to be a B cell depletion therapy, and so it takes the part of the immune system that makes antibodies and it tucks it to sleep. Not forever and not every part of it, just some part of it. And so for that reason, it's usually my suggestion for my patients before they even start rituximab to have all age appropriate vaccines. And if they're due for a COVID or a flu booster, for example, to go on ahead and do that. That said, whilst being on rituximab, if there is a need to get a booster or a vaccine, we certainly can do that. We just usually try to time it about a month or so before they would be next due for the rituximab, recognizing that at that point, that part of the immune system that was previously sleeping may probably be sleepy slash waking up, if you will. Whereas something like eculizumab or ravulizumab, will require patients to be vaccinated before they start the therapy. And if they are not vaccinated before that therapy is to start, if there's an urgent need for the therapy or so on and so forth, then those patients will go on a short course of antibiotic protection so that whilst their body is creating that vaccine response, they're protected from any sort of secondary problem. And
Okay.
it's important to note that the therapies like eculizumab and ravulizumab, they stop that membrane attack complex. That's the main reason why it works in myasthenia gravis for the most part. That's what we think to be true, at least.
Right.
Because that's what it's primarily doing. It's not changing the body's ability to respond to a vaccine. So that's why when you're on eculizumab or ravulizumab, which Soliris or Ultomiris, depending on whether you want to use brand or generic names, when you're on therapies like that, you are still able to get vaccinated when you're on those therapies, right? And it's encouraged that you get those boosters for your MenB at year 1 and 2 to 3 years if that risk is still around. And there isn't any reason to suspect that your body may not have as good of a response to those therapies accordingly, because you're not really affecting that part of the immune system completely by taking those therapies.
That actually answered Stephanie's second part of her question. Is it was about the use of potential antibiotics or alternative strategies if needed. So you covered both parts of her question. Thank you so much. Let me see. I know apparently we had our chat disabled, so I apologize to everyone. We were not aware of that. So we do have it up and running now. So I'm kind of scrolling through to see what I've missed, and I see there's something about the HPV vaccination, and Dr. Hernandez touched on that about talking with your PCP there. Is there a recommended waiting period between contracting COVID and vaccinating for it if someone with a neuromuscular disease, this says such as ALS, but any neuromuscular disease, is there a period of waiting between contracting something like COVID and getting a COVID vaccine?
I don't think it's any different than what we would normally recommend for someone without neuromuscular disease. So there, as far as I'm aware, there isn't a specific adjustment for a patient with neuromuscular disease. And if I'm not mistaken, I believe we want to wait at least 90 days or so between having had the infection and being vaccinated against it accordingly.
Okay. Okay, this is a good question too. And then I'll go back to my registration questions for now, because I believe this is the last one I see. If a patient is moving from Soliris to rituximab and have been vaccinated before with Soliris, should you continue the prior schedule? So if they received their vaccination prior to starting Soliris, but now they're changing over to rituximab, should they continue the prior schedule of vaccinations?
It's a good question. I would say it depends. And the depend part for me would be, did this person get the 3 doses of MenB and the 2 doses of MenA to start? And then we're talking about the boosters at years 1 or 2 to 3. Those would be the kind of the distinctions, right? I would say if you're someone that's wanting to complete the vaccine series for meningococcal infections, and you do have to do the 2 MenA and the 3 MenB. On rituximab, it really is a case-by-case basis whether that person is still considered to be of risk, or they would need the boosters at years 1 and 2 to 3 accordingly. And that would be a conversation with their provider. But my theory is that it would be better to complete the entirety of that series, 2 MenA and 3 MenB, before going on the rituximab, recognizing what we understand about how rituximab works.
Okay. So definitely a question to speak with your specific provider about as you're going through that change.
There's certain variables, but I understand that going on something like rituximab can certainly change our body's ability to respond to a vaccine. And so that's where my initial recommendation is coming from, but this really is a case-by-case basis.
Sure. Okay, thank you so much for answering that. We have one, is it safe to get the flu and COVID vaccines at the same time?
That's your preference. I have had some patients that have gotten it in their right arm or left arm, and left arm or right arm, and they're totally fine, being a little bit sore. And I have other people that prefer to wait a couple of weeks between them. I would say if you're someone that's considered to be immunocompromised or immunomodulated and you prefer to be a little bit more careful and cautious, and again, this is a case by case, person to person basis, then, wait a couple of weeks between getting them. Otherwise, I have had people in my patient panel that have gotten it done at the same time, and I haven't heard of any issues.
Wonderful. Thank you so much. As someone living with a neuromuscular disability, how much should I avoid contact with unvaccinated people? Just in general.
I would say if and this is a conversation to have with your neuromuscular specialist or your neurologist. It really depends on how immunocompromised or immunomodulated you are considered to be. And everyone has their own comfort level associated with that as well. I would say if you're going somewhere and you know that there's going to be people that have been sick, or you're going somewhere where there's a high possibility that you may be exposed to something and you're nervous about it, it never hurts to put on a mask and just be extra careful and cautious. But the topic of avoidance and kind of how to structure your life accordingly, that's going to be a tough call to make without having a little bit more information about that patient.
That makes perfect sense. Thank you. Let's see. Sorry, I lost my train of thought here of where I was going with my next question. It's about rhabdo. Can any of the vaccines cause more of a risk of rhabdo in people living with neuromuscular conditions?
I am not 100% sure about that. Again, there's a number of variables that are associated with someone's predilection for developing rhabdo. I know that there are certain neuromuscular conditions that can cause a higher predilection for developing something like that. And I guess it really just depends on what the specific considerations are for that patient. That would be a tough question for me to answer.
Yeah, that makes sense. And then I'm just kind of scrolling through. I see another question about should I continue to take the flu shot and COVID-19? And you've already answered that. Your recommendation is that, to get those shots. So we'll kind of move on to any other questions we haven't quite answered just yet. Let's see. Sorry, I'm just looking over to make sure I haven't missed anything. I think we've hit most of the questions so far. One just kind of overarching question I've seen is about are there any vaccines that are not safe to get? But I mean, I feel like you've walked us through all of the vaccine types and the types that are recommended and everything else. So I feel like we've kind of touched on that as well. So I'll give everyone just another moment to put any other questions that they have. There are some very specific questions in the chat that I've not addressed because they're very, specific to the individual, and so those would probably need to be spoken with their individual providers, I would assume. But here's one more question. For individuals receiving plasma exchange, since the process removes circulating antibodies, is there a general guideline on how long to wait before giving vaccines to ensure an adequate immune response?
Can you repeat the first part of that question
I
again?
sure can. Yes. For individuals receiving plasma exchange, since the
Mm.
process removes circulating antibodies, is there a general guideline on how long to wait before giving vaccines?
It depends on how often the patient is getting plasma exchange. There are some people that get it every month, every 2 months, every 3 months. It really varies. If this is someone that's getting it every 4 weeks, for example, I would say probably best to get vaccinated probably about a week or so after. If this is someone that's getting their plasma exchange every other month, then you probably could get it on the month mark in between. The main goal being to have at least 2 weeks, I would say, between the time of getting your vaccine and the time of getting your Plex. So if your Plex is on like the 15th of the month, for example, I probably would try to get that vaccine. If your Plex is on like the 15th of the month, for example, I would try to get that vaccine at the end of the month prior. I usually give that 2-week window to my patients because it's usually about how long it would take for that response to be as robust as possible. And you certainly want to capture that before you get Plex.
Okay, that makes perfect sense. And then another question, what is the difference between PPSV23 and PCV15?
Are these the pneumococcal vaccines?
I'm not sure. Katie, if you would like to guess the pneumococcal vaccines. Yes.
So PPSV 23, and what's the other one?
ECV 15.
I'm not 100% sure.
Okay.
Let me see if I can answer this for you in real time. So the PCV vaccine, it looks like it's a conjugate vaccine, whereas the PPSV23 is a polysaccharide vaccine. So we talked a little bit about these earlier with respect to the subunit, conjugate, so on and so forth vaccines. Because the PCV15 is a vaccine that contains the conjugate components, it's thought to build a stronger immune response than the other. Both of them are kind of that same category that we discussed earlier. So it really is, again, case by case basis. I know I sound like a broken record. I'm sorry.
That's okay. No.
But that would be the kind of the guidance that the one that is a conjugate would certainly have a faster and a stronger immune response mounted, but that isn't to say that the other wouldn't have a response. It would, it just may not be as strong.
Okay, wonderful. And someone posted in the chat that your answers are amazing and very helpful. So definitely do not sound like a broken record, and your answers have been very
I'm
helpful.
glad.
Yeah. So yeah, I think that we've actually taken care of all of the questions that have been in the chat, as well as most of the registration questions. So thank you so much.
You're very welcome. I'm happy to be of any sort of help or guidance. And if there's any additional questions that pop up afterwards, you certainly know where to find me.
Yeah, absolutely. If we receive any other questions, I can collect those and share those with you. I'm going to go ahead and start sharing my screen to wrap us up. But thank you so much, Dr. Hernandez. All right, let me get my bearings together over here. Let's see. I'm not sure if I am sharing the correct thing just yet.
I see your web browser. I don't see like a screen itself. Is that helpful?
Odd. Thank you. Yeah, let me try that again. There we potentially go.
It still looks like a web browser.
What's happening? Huh.
Sometimes you have to share a specific window, I've learned,
Yeah.
but I'm probably telling you something you already know.
No, it's fine. I just usually don't have a problem here, so I apologize for the delay. Give me just a moment. Let's see. I do not know why we are having a problem. Okay. Now I think we're back to good.
Yes, we are good.
Thank you. And I appreciate your all's patience as I navigated through that. I apologize. My goodness. All right. So thank you again, Dr. Hernandez, for being here and sharing that valuable information with our community members. We really appreciate you for being here. All right, so this year marks MDA's 75th anniversary. This milestone has been made possible by generations of dedicated support from people living with neuromuscular disease, their families, researchers, clinicians, volunteers, and donors who boldly drive our mission forward. So as we look ahead, we remain committed to honoring this legacy, building on the impact we've made together, and continuing our momentum toward transformative progress for people living with neuromuscular disorders. For more information, you can visit mda75.org. Before we go, I do want to be sure to let you know about MDA's upcoming events. First, MDA Advocacy Department is hosting their annual Hill Day from November 2nd through 4th. Participants will receive in-depth training on issues that matter to the community and learn the best way to have an effective meeting with lawmakers, staff, meet other advocates, and then attend important meetings with members of Congress. So it's an exciting event that's coming up for our advocacy department. And to learn more, you can visit the mda.org/Hill Day. Next, I'd like to invite everyone to join us at one of our MDA Engage in-person events later this year. MDA will be hosting 2 separate in-person educational events in Dallas, Texas on November 15th and Stanford, California on November 22nd. MDA Engage symposiums offer both disease-specific learning and general learning sessions that are applicable to all neuromuscular diseases. They're offered at no cost to the community, and attendees can also connect with other individuals and families impacted by neuromuscular disease and explore exhibitor booths to learn about different resources. I do want to be sure to extend a special thank you to our program supporters, Alexion and Biogen. And last but not least, we again invite you to join the MDA community. Joining is free and will help you stay up to date on our programs as well as on the latest research. Please scan the QR code with your smartphone or visit the link in the chat. And I'll be sure to leave the QR code up for a few seconds in case you do want to scan the QR code. I don't want to click away from it too fast, but the link will also be placed in the chat as well. And again, we would like to thank Dr. Hernandez for sharing her time and expertise with us today. We want to hear from you. So what did you think about today's program? What can we do differently in the future? Please fill out the brief survey that will pop up right after the webinar. Your feedback is important to us, and if you have any questions or looking for support or resources, please contact MDA's Resource Center at 1-833-275-6321 or via email at resourcecenter@mdausa.org. And that concludes our webinar for this evening. Thank you so much for joining us. Good night, everyone.